I have my slides, please. I'll be talking about the third hand pars plana instrumentation for the cataract surgeon. Can you put on my slides, please? Excuse me. Yeah, thank you. So essentially, let me start with this video, and this is a video presentation as to how we use the posterior segment approach, that is the pars plana approach for handling difficult cases. So these are difficult cases that we are looking at. Can you have the audio, please?
Is the backbone of this instruction course. It is imperative to understand its component and usage to fully utilize the tricks shown in the subsequent videos. A typical non-valve trocar cannula set consists of three 23-gauge trocar cannulas, an infusion pipe, and three scleral plugs. Trocar cannula consists of a sharp spear-shaped trocar, threaded over which is a round-bodied cannula. In a phakic eye, the cannulas are inserted 4 mm from the limbus. The conjunctiva is retracted slightly, and the trocar cannula is inserted in a two-step fashion, initially going parallel to the limbus for half its length and then going perpendicular to enter the sclera. The infusion is secured in the infratemporal cannula. And the superior ports used for vitrectomy cutter are plugged till further use. It is a relatively simple technique which can be mastered easily with little practice.
So friends, after giving you a brief intro as to how we can use the trocar cannula for the posterior, so you can see in this particular case, you have a intumescent cataract. Under these circumstances, you are going to have a difficulty in doing a capsulorhexis. So you start with a mini capsulorhexis and do that. But despite all these teachings, you can see that if there is a high intralenticular pressure, just doing this gives you the Argentinian flag sign. Then you can also have the problem in high IOP in phacomorphic glaucoma of a suprachoroidal breed. And you can see that this is another problem that can happen specifically in such hypermature cataracts. You can see a femtolaser can be used in such thick, such intumescent cataracts to get you a good capsulorhexis. But let us just work on seeing as to how the pars plana approach can help us. So this is a patient with a phacomorphic glaucoma, 86-year-old lady with lot of comorbidities, and the pressure was not coming down despite mannitol, topical anti-glaucoma, etc. So we decided to take this patient, and it's going to be a difficult challenge in this particular case. So let us just see as to how we are using the pars plana approach that I showed you to get a good capsulorhexis and then complete a phacoemulsification. So you can see this is the use of the trocar cannula. It's obviously a blind procedure in this case because you are not able to see. Now whatever is the fluid coming out, you can see I'm not entering with the cutter inside, and whatever fluid is coming out, we are just aspirating or cutting it out. And you can see that what this does is that the pressure of the eye falls down instantaneously. So even this removal of 0.3 0.4 ml of the fluid reduces the intraocular pressure very dramatically. And you can see that with this one can go ahead and complete a good capsulorhexis. Obviously we are starting with a small capsulorhexis which we will enlarge subsequently. But the key here that I'm trying to tell you is that if you do a vitreous decompression, in such cases, you will be able to get the capsulorhexis done. And once you have the capsulorhexis done under these circumstances, you will be able to get away with the rest of the phacoemulsification. I'll just show you that this obviously is not a terribly hard cataract, but we are able to phaco this pretty well and remove the nucleus. Once we have removed the nucleus, I'll just show you that the pressure tends to build up again. Sorry. So you can see that this is the nucleus that is being taken out. And now you can see when I'm doing the IA, you can see that there is an upthrust again. You can see that it's become a tight globe. You can see that the iris is coming. So what we do is, because we have the plug still in there, we just go ahead and repeat the maneuver without entering the eye and see the difference. The eye has become soft again. So this removal of this fluid which has been misdirected again would allow you that the iris goes in well, and we can go ahead and complete the procedure. So right in the beginning we are able to get a good capsulorhexis, and we are able to complete this procedure pretty well by doing the repeat of this during any time when the eye becomes tight again. So this is the completion of the procedure, and we put a suture and we do a peripheral iridotomy. This is the vitreous cutter which we are using to do a peripheral iridectomy in these particular cases. And you remove this, and because it's self-sealing, you really don't need to do anything, and you get away with a good outcome. So this is to show you a case of a phacomorphic glaucoma where a pars plana approach helped us in getting a good clear cornea subsequently. Now, let us again challenge another complicated case. And this, when we are challenging the complicated case, is a case with what is a traumatic cataract with a dehiscence both in the anterior capsule as also in the posterior capsule. Again, there could be a problem of a drop of the cortex, etc. But we are using the same approach that we can use, and the cutter can be used as an aspirator, or it can be used as a cutter. So you can reverse the settings of infusion, cutting, aspirating, or infusing, aspiration, and then cutting. So see here, we are going ahead, and you can see that this cutter we are using a posterior. So as has been told earlier, you don't hydrate the vitreous, and you do not increase the amount of vitreous that is coming out, and the nuclear fragments don't fall down. So this is how you work, and you can see that now we are using it as an aspirator. So you have switched the mode, and you are using irrigation aspiration. Earlier we were using it as a cutter. So you, if you get this posterior approach, you can easily take away the problem of something that is going back, and you can easily get good results in this particular case. So a posterior approach in such cases of traumatic cataract which have dehiscence both anteriorly and posteriorly would be ideal, and we can go ahead and put a three-piece intraocular lens in this particular case, as you can see that we are doing, and get a good result in such outcome, and get good outcomes in such cases. Now let us just go forward. You can see this is just the dialing and the capture. Now this is a case which is a post-traumatic, a doctor who came to me from Patna, and you can see in this particular case that we are using a femtosecond laser with a posterior approach. You can see this vitreous coming here. You can see this bead of vitreous. You can see that the iris has fallen back because it's a subluxated cataract, which I showed you preoperatively. Now the femto gives you a good OCT by which we can delineate the anterior capsule as also the posterior capsule, and despite the vitreous not being there, you can still get a good capsulotomy. Now the other advantage is that you can center your capsulotomy or decenter it the way you want, so that once you are put a ring, then the capsulotomy can be on the center. So the imaging is allowing me to put the capsulotomy as to where I want. So if we were on the scanned capsule, we were seeing that it was cutting the iris. So what we do is that we go on to custom center. So you can read here custom center. That means I'm customizing the capsulotomy onto a area where I am not cutting the iris, and we are getting a good outcome. So this is, you can see we have done a capsulotomy, etc., the nucleotomy. And here again, what you are seeing is in the OR we have injected tricot, and we are using the third hand, that means the pars plana approach, to remove the vitreous which was coming there. So what will this do is that it will stop the hydration of the vitreous, and the extent of the subluxation will not increase. So I have a good capsulotomy because of the femto. Now I am putting the ring and I have a nucleus that has been disassembled. So the amount, despite low fluidics, I'll be able to disassemble and eat away the nucleus without much of a problem. So you can see that this is the advantage that we have, and we are able to remove the nucleus. You can see that because of the earlier removal of the vitreous, I am not getting any increase in the subluxation that was there. So mind you, the posterior approach has helped us significantly in this particular case by decompressing the posterior, the vitreous that was coming in. We are having the advantage of a much more stable bag, and we are having the advantage of a disassembled nucleus. And now we are doing a bimanual irrigation aspiration in this particular case, and you can see that we will have a great outcome. We are putting a three-piece lens in addition to the CTR that we had put, so that, and now at the end again we go in with the cutter to see that there is no vitreous that is left, and we can disenclavate the vitreous which was going into this wound here. So you can see we are disenclavating. You can see this is the vitreous, the tricort is showing again, and you can see that this tag which was there has been disenclavated, which has been done. And now we go ahead, remove the plug, and put infusion from here, and then take the cutter from the other side. So once we have the cutter from the other side, this vitreous tag is also removed, and we get an excellent outcome. This is the post-op picture, and the patient is happy with the outcome that is there. So this was another case that I wanted to show you, where we used the third hand, as I would say, a pars plana approach to get onto a good outcome which is there. Now, I think Shreyas will cover it in more detail, but you can use a chandelier's illuminator where there is a point source of light which is being put directly onto the retina, and you are getting a retroillumination. So you can see this again would require the use of the third hand, where we will switch off the microscope light so you can see the difference. We have put in a chandelier's illumination, and this is a self-retaining chandelier fiber which provides good visualization. It's a self-sealing wood that is retained. You can see this is a case of a corneal opacity, and once you have the corneal opacity, we just going to see that if I was to do the surgery in this particular case, it would be slightly more difficult. So we are using the pars plana approach. You can see that we have done the chandler's illumination, and once you have the chandler's endo illuminator in, you can see that this corneal opacity has just vanished, because the microscope light actually diffuses the whole thing and causes a problem. And you can see this is the same cornea which we are using the pars plana approach with a chandelier's endo illuminator, and in such corneal opacities you can get great outcomes. The depth perception is actually pretty great, and I we will show you more of the chandelier's endo illuminator, which is again we can have a posterior segment surgeon helping us in this particular case. So you can see this is the irrigation aspiration that is happening. Mind you, the such dense corneal opacity is really not causing. This is the intraocular lens that is going in. You can see this corneal opacity which was there, which there are two corneal opacities, and this is the lens that is being implanted into the capsular bag. So friends, you can see this is the corneal opacity. So what I wish to highlight, this is again another case with a blast injury. Patient came from I think Afghanistan, and in this particular case again we are using the chandler's endo illuminator. We did a capsular access. You can see that we are able to get away with this, and this is the use of a Busen glide. This is for doing DSEC, again anterior segment approach. You can see that we get good endo illuminator, etc., that we can do. So what I call this is the third hand for you, which helps you in tackling and picking up the challenge of such complicated tough cases to get good outcomes of phacoemulsification. Thank you very much for your kind attention. Thank